Hello, my name is Robert Brill. I'm a fibromyalgia advocate and a PhD candidate in health psychology, and this is my fibromyalgia podcast series. Today I'd like to discuss chronic pain states. Recently I attended a conference from 2012 featuring the research of Dr. Doley's audio digest on psychology and chronic pain states. He discussed psychosocial approaches to pain management and how clinicians can implement evidence-based psychological and psychosocial aspects for chronic pain management. Pain is an evolving concept, and leading experts consider current pain definitions as very fluid. Recently, pain has been called a problem of homeostasis, or a dysregulation in the body. But today we're still really undecided as to what pain actually is. Even though we recognize pain as whatever, wherever, and whenever the patient says it is, pain is a biopsychosocial problem, meaning that if you haven't evaluated the biology, the psychology, and the sociology, then you haven't truly evaluated pain. Pain is a perception, a product, and a byproduct of an emergent phenomenon. Pain as an emergent phenomenon means that it's bigger than the sum of its parts, but it cannot be broken down into its parts, meaning it has to be viewed as a whole. Many physicians don't view pain as a whole. You cannot have pain without some psychological factors, otherwise you wouldn't be alive. If you have pain from an injury, there may be some psychological impact from the pain, but as the etiology of the pain becomes more generalized or vague, as is seen in fibromyalgia, the higher the likelihood will be that there's a greater impact to the outcome. What about pain conditioning? Studies suggest that there's a possibility for people to condition pain, especially considering the placebo response. After a while, electrical impulses in the spinal thalamic tract will be present, even prior to the stimulus of pain, and this is called conditioned nociception. What I'm going to say next is a critical piece of the chronic pain that we suffer from with fibro. Conditioned nociception means that our expectations of pain, they actually condition us to experience more pain than we should. We can have pain without any physical stimulus. Think of phantom limb pain. Pain can be present with people who lost a limb, but it can also be present in limbs that never existed, as is seen in a child being born without an arm, for example. If there is a pain generator and you stop it, the pain still exists most of the time, especially with chronic pain like fibro. Some ways of coping with pain are to overcome it, ignore it, increase activity, praying, hoping, reinterpreting the pain, or diverting your attention elsewhere. And these may or may not help. Acceptance to illness isn't giving in to it. Instead, it's a realistic appraisal of your situation. It provides perspective, and it is a coping mechanism. If you're sitting around at home waiting for your pain to begin or to get worse before you are likely to not get any better, regardless of what is done. If you're expecting pain, pain is what you'll get. There has to be commitment in spite of the pain. It has to be realistic to physical pathology and to your abilities. There are things we can do. Is it going to hurt? Most likely. But if we wait for the pain and the symptoms to stop prior to rejoining our life, then we are going to have a huge problem regardless of what we try to do, and we'll never rejoin our life. So acceptance becomes critical, more so than coping skills. Until we accept what we have and that we are in control of our wellness, and that we can get better, then the coping skills are meaningless. It's like the placebo response. The placebo effect has shown us that the mind can heal. When we seek treatment for chronic illness, we ask our clinicians to do whatever they can to help us, and they do their best. They exhaust medical insurance options, behavioral therapies, medications, fusions, surgeries, or whatever. And then clinicians marvel at the patient that they aren't better, and they say, well, the treatment was successful, but the patient didn't respond. And this is most commonly seen with those who treat chronic illness patients. What about cognitive behavioral therapy as a great modality for chronic pain and chronic illness? Cognitive behavioral therapy literally changes the brain. It's brain management, or brain washing in the positive sense. Getting rid of the bad and replacing it with the good causes good things. Everything in your life makes sense, and it makes a difference in your brain chemistry, especially catastrophic thinking. You're capable of directing what physical changes happen in your brain, especially through cognitive behavioral therapy. This is documented over and over again. If you measure the brain volume of a chronic pain patient, their cortical brain matter shrinks over time and as a result of pain. Chronic pain is a progressive disease with a neurodegenerative component. Brain damage does in fact occur. So when we hear from our clinicians that fibro is not degenerative, I beg the question, don't we in fact see neurodegeneration when facing chronic pain? Yes, yes, and yes. If not addressed, pain will continue to develop. Cognitive behavioral therapy can partially reverse the central atrophy associated with chronic pain, thereby reducing neurodegeneration. What about the expectation of pain? Uncertain expectations enhance the anterior cingulate brain response, causing us to begin feeling all stimuli as painful, even the non-painful stimulus like putting on our socks or brushing our hair. So if we expect that our pain will be horrible, we force changes in our brain. Intensity and unpleasantness of the pain are two components that have to be looked at regarding quality of life. Response to a somatic stimulus in the central nervous system can be exaggerated by our expectations as well. Suppressed emotional thoughts, worries, and fears tend to reoccur, especially under mental load or unusual intensity. In terms of pain, we need to accept versus suppress, and modify versus ignore. We accept that our condition comes with some pain, and we do not suppress the pain. And we modify our behaviors to keep on going versus ignoring the pain, which forces us to withdraw from life. Over a long period of time, you can no longer overlook pain, and your pain will get worse. So again I ask, what about the perception of pain? There is a survival value in protecting our memories. When something bad happens, connections are made in the brain, making them permanent. There will be a connection that creates a memory, and if it has significance, there will also be a perineural net produced, which is a group of structures that encompass memory, networking protection, and it protects us from being destroyed. The significance of this is that it makes a painful memory permanent. So as pain becomes a memory, in some cases it becomes protected and permanent. This permanence has a survival value, no doubt. We don't want to deny or ignore these memories. Instead, we want to learn how to do different things in their presence, accepting them, reacting to them, and dealing differently with them. Let us also look at controlling the secondary psychosocial aspects of pain, like our financial problems, our work issues, relationship issues, or generally just too much stress. How many of our symptoms do we cause by not managing our lifestyle? What can we accept responsibility for? Accepting responsibility will reduce our symptoms, and clinicians need to attempt to understand the pain generator if one exists. Often, it's not in the periphery or the spinal cord. It's in the brain, as was seen with fibro. So if we want to not hurt anymore, we change our brains, for example, using cognitive behavioral therapy. All the drugs in Western medicine in the world may not help with some chronic illnesses, meaning they won't change the brain chemistry. The brain may react a little, sometimes, but it's not enough. Often what we see in fibro is that pain meds don't remove the pain, they just make you care a little bit less about the pain that it is present. This isn't what we should be looking for. It doesn't suppress the intensity or sensory component of the pain, but it alters the unpleasantness and the brain's emotional reaction to the pain. That's not a cure. Hell, that's not even acceptable to most of us in the way that symptom relief. What about depression and pain? Most people who have depression and pain will complain about the pain versus the depression, due to a fewer stigmas about the pain most likely. Plus, depression doesn't hurt quite as much as physical pain, and sadly, insurance pays better for pain symptoms versus depression symptoms. Sometimes treatment is driven by insurance, sadly. Not always the most effective treatment, though. Studies have shown that patients with pain and depression who were just treated for the depression reported pain decreases of like 30%, with depression decrease of like 50%. So treating the depression is as much or more valuable than treating the pain in many cases, especially with fibro. But remember that antidepressants have analgesic value and reduce pain too. The basic substrates of pain involve norepinephrine, serotonin, and dopamine. Aggressive depression treatment is a valuable part of pain management in general. The long-term goal, though, is to get off pain meds or antidepressant meds and manage your illness on your own. I want to touch a little bit about heart rate variability. With medically unexplained symptoms, as is seen with fibromyalgia, heart rate variability is typically seen. It adjusts moment to moment according to our environment, our pain, or our stress loads. So we combine psychology and medicine to view a systems analysis versus a symptom or behavioral analysis. So with fibro, you don't have good coherence. You have an inconsistent variability of heart rate. And this is where biofeedback can help reestablish coherence and a normal heart rate. Biofeedback has been shown to reestablish heart rate variability to normal. And this is something that we should look at with fibro. What about dysregulation in fibro? Dysregulation can be applied to fibro, which means the body stops adjusting to the demand put on it. When this happens, it can be a prelude to death, at least in theory. When the organs no longer do what is expected of them and they stop adjusting accordingly, eventually systems begin to fail. I'm doing some research on this in this area, and I think that there's plenty of merit here. MRIs show what part of the brain is reacting, and using biofeedback, the patient can be taught how to change the anterior cingulate gyrus to alter this activity in the brain. Distracting these cortical processes helps the pain coping mechanisms. In a study of patients in hospitals that had private rooms versus semi-private rooms, the patients in the private rooms used more pain meds and expressed more pain to their caregivers, suggesting that this disruption and commotion in the semi-private rooms from all the people coming in and out probably caused a distraction of the cortical processing, resulting in the patient requesting less pain meds. So when they're surrounded by people, they experience less pain. The worst thing a patient can do is nothing. Something very interesting about pain that one study showed was that a patient with multiple personality disorder actually had 5 personalities. But the funny thing is that 2 of them didn't have any pain. And this means that pain can be controlled or managed. Stages of Change discusses the willingness to be ready for the change for wellness. If a patient has 3 or more risk factors, like a history of physical or sexual abuse or alcoholism, they have a much higher likelihood to not get better, even with treatment when they suffer from chronic pain. This is known as self-directed neuroplasticity. Essentially, our maladaptive thoughts impact our pain expectations. So the takeaway message here is that our brain is constantly changing according to what we feed it. If we feed our brain positive things, we get positive outcomes. If we are negative about our disease, if we catastrophize about our symptoms being severe, if we expect that our symptoms will never go away, we change our brain to succumb to these expectations.